Hello, everyone. I gave this lecture to an audience of neurologists and infectious diseases doctors a few months ago. My title slide shows the essential elements of neurotoxic envenoming by snakes, in this case, a Malayan krait. So at least two classes of neurotoxins acting at the neuromuscular junctions, and the ultimate effect of that is an almost totally paralyzed patient you see on the bottom right. This lecture is named after Richard Tidball Johnson, a very famous American neurologist, father of neurovirology, author of many publications and influential textbooks. He had wide training in the United States, in UK and in Australia. And he's really particularly associated with Johns Hopkins, where he was known as RTJ. He co-founded the Department of Neurology and worked there from 1969 to 1997. Amongst his most distinguished collaborators were Carlton Gajdusek. He then moved in retirement to found the National Neuroscience Institute of Singapore. And my wife Mary and I met him in Bangkok in the 1980s when he was working at AFRIMS, particularly on Japanese encephalitis with our colleagues Charlie Hoke and Don Burke. Well, I failed to interest RTJ in snakebite, but I would argue today that snakebite neurotoxicity, direct and indirect, has some relevance to both neurology and infectious diseases. Look at it in this way. In the middle there, we have some shared features, so neuromuscular transmission block, autonomic nervous system stimulation, and so on. And on the left, the forms of snakebite envenoming that involve these abnormalities. So, for example, elapid and viperid neurotoxicity act principally at the peripheral neuromuscular junctions. Autonomic nervous system stimulation is associated with envenoming by other snakes, and those venoms that cause coagulopathy and bleeding can result in intracranial hemorrhage or thrombosis. Finally, an indirect effect, Russell's viper, causing acute hypopituitarism, presenting with neurological features of profound hypoglycemia, and coral snake envenoming causing excruciating pain. So the neurological parallels I've put in here. So great similarities between myasthenia gravis, the autoimmune disease, and neurotoxic snakebite envenoming. Autonomic nervous system stimulation, you see there, and of course intracranial hemorrhage and the cerebrovascular accidents, and the hypoglycemic effects you might see with insulinoma or Addison's disease, and excruciating pain associated with thalamic lesions and some of the painful peripheral neuropathies. When we switch to infectious disease, again, I'd like to make the argument that there is relevance of snakebite effects. So certainly with botulism, you get neuromuscular transmission block and autonomic nervous system stimulation. I've listed some conditions there. For intracranial hemorrhage or thrombosis also, and profound hypoglycemia occurs in sepsis, shigellosis, for example, in severe falciparum malaria. And finally, painful lesions are familiar for herpes zoster. Now, the evolution of lethal snake venom toxins was driven really by the snake's need for prey, for predation, and also perhaps for defense. So the snake's venom toxins evolved really to commandeer physiological pathways in their prey or enemies, targeting receptors that are central to these critical physiological processes. This allowed snakes to prey on much larger, stronger, quicker, and legged quadruped animals by causing disastrous drop in blood pressure, massive intravascular thrombosis, so in the in the heart chambers and great vessels, paralysis, and intense pain as a distraction from the attack of the snake. And I saw this process enacted in the roof of the kitchen of this, where I was on safari in Savo East in Kenya a few years ago. A pencil-thin snake, an Arabian tiger snake seen here, had grabbed a large, very strong and active lizard and has it fastened around the neck, injecting venom, but also wrapped its body around to restrain it. A little later, early signs of envenoming are visible in the lizard. You see that it's developing ptosis. And this ended up with the snake able to swallow this now completely paralyzed large prey, and was able to swallow the whole thing. I have to give you a brief idea of the two main groups of venomous snakes that can cause effects on the nervous system. Predominantly the Elapidae, famous snakes, cobras, kraits, mambas, and so on. And all the Australasian venomous snakes and all the sea snakes are in this family. These are relatively long, thin, and usually uniformly colored, although with exceptions, and are relatively fast moving. And the venoms of all these elapids contain either pre and or postsynaptic neurotoxins causing paralysis. So here's a cobra and another cobra from Asia, and an exception to the rule of uniform coloring. The only elapid snakes in the Western Hemisphere are the coral snakes. The other group, the Viperidae, so vipers and adders, pit vipers, and so on, the North American rattlesnakes and moccasins. Compared to elapids, they're relatively short, thick, and short-tailed. They usually have a colorful dorsal pattern, which is useful for identification. They're relatively slow-moving, but they can strike like lightning. And some of these vipers possess presynaptic toxins in their venoms. So here's an example, Francesco Redi's viper, which can cause mild neurotoxic effects. That's a European viper in Italy and so on. And in the Americas, in South America, this is the tropical rattlesnake, whose venom is also neurotoxic. And there's just one species of another very large, mainly non-venomous family, the Colubridae, that can cause some neurotoxic effects. So here's the neuromuscular junction in vivid technicolor. This is the target of the most important neurotoxic features of snakebite envenoming. And a simple classification, presynaptic or beta neurotoxins destroy the nerve terminal. They damage the nerve ending, so initially causing release of acetylcholine transmitter, but eventually complete disruption of the transmitting mechanism. Compared to the alpha or postsynaptic neurotoxins, which are competitive inhibitors of acetylcholine at the receptors on the muscle side of the neuromuscular junction. Of course, it's far more complicated than that. And for those of you who are interested, this is a much more comprehensive description of the many neurotoxin receptors and possibilities at the neuromuscular junction. And some examples of important neurotoxins, for example, beta-bungarotoxin, shown there, which is a combination of a phospholipase with another molecule, which target voltage-gated potassium channels, and possessed by Elapidae and some of the Viperidae, as I've said before. This produces an irreversible neuromuscular block because the nerve terminals are destroyed, and results in a descending flaccid paralysis, which is refractory to to treatment. It can't be reversed acutely. Whereas the postsynaptic or alpha neurotoxins, a bit like curare, have a three-finger-fold structure which enables them to clip over the acetylcholine receptor at the neuromuscular junction. An example would be alpha-bungarotoxin. These block the nicotinic acetylcholine receptors. They're possessed by many elapids and just a few colubrid snakes, and produce a reversible block, causing again descending flaccid paralysis. And two toxins peculiar to the mambas, the most dreaded genus of African elapid snakes, the dendrotoxins, which are pear-fold shaped and target voltage-gated potassium channels of particular classes, and fasciculins, which destroy endogenous anticholinesterase and therefore perpetuate the action of endogenous acetylcholine. Both these types of toxins result in fasciculation, resulting either from massive release or inhibition of breakdown of endogenous acetylcholine. So the clinical effects of these very interesting neurotoxins, I'm showing you here in a 9-year-old boy I looked after in Papua New Guinea. He'd been bitten by the Papuan taipan, a really formidable oceanic elapid snake. Here he is 4 hours after the bite. The earliest feature of neurotoxicity is usually bilateral ptosis with external ophthalmoplegia. See, he's puckering his forehead, contracting his frontalis muscle, trying to open his eyes. And then a bit later, he develops features of seventh nerve paralysis. Unable to keep his eyes closed, unable to keep his lips pursed, and unable to show his teeth fully. And progressing to time when he was unable to open his mouth or protrude his tongue. And he showed this very interesting feature, which I think should excite neurologists. When asked to look to the left here or to the right, the abducted eye showed jerky nystagmus, whereas the adducted eye was paralyzed in the mid position. This would be described as internuclear ophthalmoplegia or pseudo-internuclear ophthalmoplegia, because whereas in conventional neurology, this ataxic nystagmus is associated with lesions of the highly myelinated medial longitudinal fasciculus, this is definitely not involved in snakebite envenoming because it's in the central nervous system, and these neurotoxins don't penetrate into the central nervous system. So the bilateral palpable ptosis is the earliest feature, right, the most sensitive feature of a variety of causes of paralysis, toxic and other paralysis. So here again is another patient with taipan envenoming, showing bilateral ptosis. 2 autoimmune diseases, myasthenia gravis and Lambert-Eaton syndrome, again presenting with bilateral ptosis. Botulism, a bacterial toxin, again with the same type of presentation. Miller-Fisher syndrome, and 2 types of inherited mitochondrial abnormality, Kearns-Sayre syndrome and chronic progressive external ophthalmoplegia, again starting with ptosis. And don't forget, by the way, that some people have ptosis, congenital ptosis. It can be very misleading if you're examining a patient and think that they've got some early signs of paralysis, whereas in fact they've had it all their life. So the question here is, why are the external ocular muscles more vulnerable to neuromuscular blockade. Why does bilateral palpable ptosis, why is it the presenting feature of many of these conditions? Well, I think there is an explanation, because external ocular muscles differ from other skeletal muscles in many ways. First of all, they're very diverse in their structure. The myosin and myosin fibers and nicotinic acetylcholine receptors are present in a number of different isoforms. They're innervated either singly to produce rapid twitch or multiply to produce tonic firing, often at very high frequencies. And I think this is the crucial point. Twitch fibers have less prominent synaptic folds and fewer acetylcholine receptors. And this results in their having a lower safety factor. This is the safety factor here, end plate potential divided by the difference between the action potential threshold and the resting potential. This will make them more vulnerable to blockade by snake venom toxins, neurotoxins. The EOMs also have a very rich blood supply and a high metabolic rate, and they're particularly vulnerable to complement deposition, making them targets for autoimmune diseases. So here's an example of a myoneural junction in a mouse extraocular muscle, showing the lack of folds in the membrane and the very rich supply of mitochondria, evidence of this high metabolic activity. Well, a clinical feature, a striking clinical feature of snakebite neurotoxicity, but also, as I'll say in a moment, of other types of paralysis, is a progressively descending pattern. So as I've said already, the earliest sign is likely to be ptosis with external ophthalmoplegia and effects of the pupils as well, progressing to problems with opening and closing the jaws, facial paralysis, involvement of the bulbar muscles, here with the danger that the patient may aspirate, and then some of the accessory muscles of respiration. And when the 12th nerve is involved, problems with tongue protrusion. Then it progresses further to the muscles innervated by the cervical nerves. And there's a sign which I'll show you in a moment, the broken neck sign, which is paralysis of neck flexion, and more serious paralysis of the diaphragm, affecting respiration. Then the upper limbs and flexion of the index finger, and then final progression to the thoracic and lumbar nerves, as you can see here. And here is this classical progression illustrated in a patient envenomed by a Malayan kite, Bungarus candidus, in eastern Thailand. So at 3 hours after the bite, you can see he's got early ptosis and external ophthalmoplegia. This progresses to a point where after 4 hours, he's unable to open his mouth and protrude his tongue. And at 7.5 hours, he requires assisted ventilation. He now has almost total flaccid paralysis, as you can see here. Life is maintained, in this case, by manual assisted ventilation. But I'm glad to say that he made a complete recovery and was discharged from hospital 6 days later with only a hint of bilateral ptosis. Here is the so-called broken neck sign, signifying involvement of the neck flexors innervated by the first and second cervical nerves. Another example here. And a man from Bangladesh with sea snake neurotoxicity. He's scarcely able to flex his neck, but after being given some anticholinesterase, he is able to flex. And I'll be coming later to mention the effects of anticholinesterase, neostigmine, drugs like that, in ameliorating to some extent postsynaptic neurotoxicity. Well, the end point of descending paralysis in snakebite patients is an unconscious, apparently unresponsive patient with a Glasgow Coma score of 3, with fixed dilated pupils, and with possible inferences of locked-in syndrome or even brain death. And here is such a case. This girl, a 9-year-old girl in Saigon in South Vietnam. I saw her nearly 60 hours after she'd been bitten, again by a Malayan crate in Vietnam. And the clinical picture was of total flaccid paralysis, fixed dilated pupils, and a Glasgow Coma score of only 3. And the expert team looking after her inferred that she'd suffered ischemic brain damage sustained before she was intubated, and her respiration was supported in the face of this progressive flaccid paralysis. So here she is with bilateral ptosis. The first thing we did was to open her eyes so that at least she could see potentially. You see here her fixed dilated pupils. We then asked her, of course in Vietnamese, try to move your toes. And to the enormous surprise of some of those around the bed, she was able to flex her big toe. And it was quite clear, using simple language, yes, no, flexing her toe and so on, that she was fully conscious. She could see, hear, and could feel, and yet was unable to communicate these sensations. Now, the second question I'd like to pose to neurologists is, why do some progressive paralysis descend and others ascend? I thought this was very intriguing, speaking as a non-neurologist. Amongst the classically ascending paralyses are Guillain-Barré or Landry syndrome, hyperkalemic paralysis, tick bite paralysis, rabies encephalomyelitis, and neuromyelitis optica spectrum disorder. The explanation I've been given for this is that the longest axons are the most vulnerable. For example, the lumbar roots travel greater distances through the cerebrospinal fluid and therefore exposed perhaps to autoantibodies before they leave the spinal column. Then there are the classically descending paralyses. So those caused by snake venom neurotoxins, tetrodotoxin fish poisoning, that's pufferfish poisoning or fugu poisoning, paralytic shellfish poisoning caused by saxitoxins, botulism I've mentioned before, and the myasthenia gravis and Lambert-Eaton syndrome autoimmune complex. But in this case, answer came there none to my request for an explanation. Really does seem to be extremely puzzling. And I'd be very grateful to hear if any of you have ideas about this. An alternative view of snake venom paralysis, contrary to the one I've been giving you, was given by a group based in Sri Lanka. Rather than seeing a progressive pattern, they see 2 distinct patterns of neuromuscular weakness involving different nerve and muscle groups, perhaps depending on neurophysiological differences between the different neurotoxins injected. So they see these 2 separate patterns: ptosis with extraocular muscle weakness, an early common feature, and respiratory muscle weakness, later and less common. And they didn't seem to see any progression of paralysis through intermediate stages, or even a further progression to near generalized flaccid paralysis. And it is this progression, as you've heard, which has been my overwhelming impression at the bedside of very many cases of neurotoxic snake envenoming. So that's the end of the first part of this talk. Continuing my Richard T. Johnson lecture, so far I've told you about the classic progression of descending flaccid paralysis, typical of snakebite, neurotoxic snakebite envenoming. But there are other possible effects of snake venom toxins on the nervous system. For example, muscle hyperexcitability in the form of either fasciculations or myokymia, autonomic nervous system stimulation, overwhelmingly painful envenoming, and acute and persistent as anosmia as a complication. Then there are some unconfirmed or controversial effects. For example, effects on the central nervous system are controversial because it's doubtful if any of the snake venom toxins penetrate the blood-brain barrier, but that's still open to investigation. Acute neuropathy is also controversial. And finally, a delayed persistent neurological disturbance following presynaptic neurotoxic envenoming with damage to neurons, with depletion of the population of neurons, a bit like post-poliomyelitis syndrome. So I'm going to tell you a bit about fasciculation and myokymia. The venoms of African mambas, they're the 4 species illustrated there, and on the right, a South African victim of black mamba neurotoxicity with typical bilateral ptosis and so on, progressive paralysis. But a particular feature of mamba neurotoxic envenoming are these fasciculations. And these are single spontaneous discharges of individual motor units, producing brief twitches of a group of muscle fibers innervated by the same motor neuron. And on the electromyogram, these show as single random motor unit potentials or doublets, but they're never recurrent. The causes are dendrotoxins, these pear-shaped neurotoxins, which stimulate neuronal voltage-gated potassium channels, releasing endogenous acetylcholine. And some mamba venoms also contain a specific venom, fasciculin, which is an inhibitor of endogenous anticholinesterase. So both these types of mamba toxin have the same final effect of overwhelming acetylcholine stimulation. Here's an example of fasciculations in a victim of black mamba bite at St. Mary's Hospital, Lekor, Gulu in northern Uganda. I'm sure you're familiar with fasciculations, and most easily seen in the tongue, where it's really a matter of fibrillation rather than fasciculation. So you see this fine twitching of muscle fibers innervated by individual spinal motor neurons in this black mamba victim. And there's another type of muscle hyperexcitability known as myokymia, which is subtly different. This occurs after envenoming by a variety of Western Hemisphere pit vipers. On the far left, the common lancehead Bothrops atrox from Latin America, and all the others are rattlesnakes, genus Crotalus. So myokymia, unlike fasciculations, produces an undulating rippling of the muscles, and on the electromyogram, this is apparent as myokimic discharges, spontaneously generated bursts of individual motor unit potentials, each burst recurring rhythmically or semi-rhythmically several times per second. So here you see discharge 4 here, or 2 here, or 3 here, in this record taken from a patient envenomed by this timber rattlesnake, Crotalus horridus. The form of myokymia seen in snakebite victims, first of all, bilateral facial myokymia, and also myokymia in muscles close to the site of the bite. And this is, if this is close to the respiratory muscles, then this sometimes causes respiratory muscle embarrassment and even respiratory muscle failure. The causes are still unidentified venom ion channel toxin that increases peripheral nerve excitability, acting on axons, peripheral axons. And the effect can be abolished by raising the circulating ionized calcium concentration by infusing calcium chloride. So here's an example, an 18-year-old man bitten on his left hand in California, kindly by permission of my friend Sean Bush. So you see these slightly coarser, coarser than fasciculations, so-called undulating patterns of involuntary skeletal muscle contraction. I think very well illustrated in this young chap who's been bitten by a rattlesnake, a southern Pacific rattlesnake. And here's another example from Trinidad of the common lancehead, Bothrops atrox. Another example of myokymia. Also in this patient's thigh. Obviously an uncomfortable, even painful sensation. The autonomic nervous system may be stimulated by some snake venom neurotoxins. And I want to show you a case history now. This is a 39-year-old Danish tourist lady who was on holiday in Trinidad. And she was jogging in a bird reserve when the Western Hemisphere's largest venomous snake, a bushmaster, bit her behind the knee. This is the snake, nearly 2 meters long. They grow much larger than that. Within only 15 minutes of the bite, she was nauseated and was vomiting, had uncontrollable diarrhea, and she collapsed but remained conscious and was bleeding profusely from the fang puncture marks. An hour later, when they finally managed to get her to hospital, the nearest hospital, her blood pressure was reduced with a disproportionately slow pulse, considering the low blood pressure. She was distressed, sweating, repeated bilious vomiting, and still bleeding from the fang marks with a swelling and very painful leg. Her blood pressure was restored with intravenous fluids. And here are her own photographs courageously taken of the envenoming, showing these multiple fang and tooth marks here with subsequent bruising, as this snake venom causes coagulopathy and bleeding. So autonomic syndrome after bushmaster envenoming is typically fairly soon after the bite, with the symptoms that you've seen illustrated by this patient, by the Danish tourist, with gastrointestinal symptoms, a fall in blood pressure with bradycardia, shock, collapse, and very often loss of consciousness, and profuse sweating caused by parasympathetic and sympathetic overactivity. Another unusual type of envenoming involves not just the ordinary sort of pain of snake bite. I mean, most snake bites are painful, but this is overwhelming pain following envenoming by the only genus of venomous elapids in the Western Hemisphere, the coral snakes. So again, a case history. This was a 27-year-old young Ecuadorian man working for the National Geographic as a cameraman. He was bitten on the hand by a large tropical coral snake in the eastern jungle of Ecuador. Fairly soon afterwards, he developed agonizing and intractable pain and paresthesiae in his bitten arm. And these symptoms persisted for 9 hours and were the dominant clinical features. And we tried everything to control it: intravenous diazepam, ketorolac, morphine, multiple doses of morphine, midazolam, and so on. And a very similar case was described by a colleague of mine in Brazil, bitten by the same species of coral snake with intractable pain. Our particular patient in Ecuador finally developed more typical, more expected symptoms of elapid envenoming, that is, classic descending paralysis, which eventually required mechanical ventilation. But these more typical neurotoxic symptoms started only 14 hours after the bite, after the very severe pain had resolved or had been controlled. So here is the specimen of snake that actually bit him. Here he is showing signs of typical neurotoxicity, bilateral ptosis, and so on, 14 hours after the bite. And I'm glad to say he made a full recovery. This is written up in the journals. Well, we now have a very good explanation for this agonizing pain after coral snake bite, because it's also found that the Texas coral snake, Micrurus tener, causes severe pain that is out of the ordinary pain in 16% of cases. And this venom was studied in the laboratory, found to excite a large cohort of sensory neurons in experimental animals and preparations, and purified toxins from this venom, which consists of a Kunitz protease inhibitor coupled to a phospholipase A2, were found to be potent, persistent, selective agonists for acid-sensing ion channels, or ASICs, on capsaicin or chili pepper-sensitive pain fibers. So here is the structure of the coral snake pain toxin. And this work was carried out in the laboratory of David Julius, who some of you may remember won the Nobel Prize for Medicine back in 2012 for his work on pain. So the coral snake pain problem was just one of his models of his investigation of the mechanism of pain. Persistent loss of taste and smell. This may recall the COVID-19 epidemic, typical of bites by the South African bergadder, Bitis atropos, illustrated here, but also by the same Southern Pacific rattlesnake that produced that spectacular myokymia that I showed you, and a number of species of Australasian or Oceanian elapid snake, particularly the tiger snake and black snake, and this brown snake, the mulga snake. And here is in at least one case where imaging was carried out showing damage to the olfactory bulb caused by this venom, implying a specific toxin targeting the olfactory fibers and leading in some cases to permanent loss of the sense of smell and taste. Now on to some indirect neurological effects of snakebite envenoming. Intracranial hemorrhage or thrombosis is a serious and very often fatal complication of coagulopathic envenoming. This is typical envenoming by the Viperidae and some Elapidae as well, the Australian ones, in which there are abnormalities of clotting factors, platelet dysfunction, and damage to vascular endothelium, all these resulting either in bleeding or in thrombosis. So in the case of Viperidae, oceanic Elapidae, and a very few species of colubrid snake. So here's a Nigerian boy I looked after who presented with what was initially suspected to be meningitis. He had a stiff neck, and he's here showing pain on attempted flexion of his neck. But in fact, he'd had a subarachnoid hemorrhage after being bitten and envenomed by a notoriously hematotoxic snake in the northern third of Africa, in this case, the carpet viper Echis romani. And here's an even more extensive intracranial hemorrhage following a bite by the mulga snake or king brown snake in Australia, showing these multiple hemorrhages, this one with a fluid level indicating that the blood was incoagulable. So intracranial hemorrhage or thrombosis, as I say, is a really dangerous development in late presenting or uncontrolled hematotoxic envenoming. In this particular patient in India, in Rajasthan, she had unequal pupils, so ipsilateral dilated pupil. And here, this shows the hemorrhage, cerebral hemorrhage, again with a fluid level indicating that the blood was incoagulable. And some other examples of extensive hemorrhages, in this case by, in this case a Russell's viper, in this case by a North African horned viper. And it's not just hemorrhages, the greater availability of cerebral imaging has now allowed us to identify infarction as well. This Russell's viper case showing an infarct. And a cortical venous thrombosis illustrated here in this MRI flare. So some other indirect neurological effects. Russell's viper venom has a devastating effect, seen particularly in Burma, of causing hemorrhagic infarction of the anterior pituitary. So this is a view of the base of the brain at autopsy. That's the optic chiasma, they're the corpora quadrigemina, these are the olfactory tracts. An infarcted pituitary that can cause acute pituitary adrenal insufficiency, presenting with typical features of profound hypoglycemia, not just the familiar anxiety and tachypnea and so on, sweating, but also involuntary movements and so on, and even decerebrate and decorticate rigidity. Other effects that have been described are optic neuritis, Guillain-Barré syndrome, cereballitis, acute disseminated encephalomyelitis, and acute hemorrhagic leukoencephalitis. And here's an example of what has been described a few times, posterior reversible encephalopathy syndrome, and showing that it often area of predilection in the occipital lobes. Finally, some effects, indirect effects on the peripheral nervous system. This patient, envenomed by a saw-scale viper in Nigeria, has inability to flex his left leg, and this is attributable to a hematoma pressing on his iliacus area, pressing on his femoral nerve. I was very surprised to see this in Nigeria, but when I spoke to colleagues who run haemophilia clinics in this country, in the United Kingdom, they said this was not an unfamiliar complication in haemophilia patients. Hematoma formation in the pelvic cavity causing pressure on the femoral nerve. And another example of a peripheral nerve lesion, this is a right common peroneal nerve palsy, so he's unable to flex or evert his right ankle. And the problem here was that a very popular form of first aid is the application of a tight tourniquet just below the knee that compressed the common peroneal nerve. In this case, it was for a Russell's viper bite. So that's the site of vulnerability, and that was the level at which the this tourniquet was applied. Well, I should say briefly about the treatment of neurotoxic envenoming. First aid treatment is aimed at limiting the spread of venom toxins from the site of the bite where the venom has been injected. And this can be achieved by applying pressure over the bite site. So you're compressing veins and lymphatics that would normally carry the venom away from the bite site and make it a life-threatening systemic problem. The medical treatment when the patient reaches medical care is resuscitation, which may involve rapid intubation and clearance of the airway, rapid clinical assessment, and, if possible, species diagnosis. Antivenom is the specific antidote, but of course it's not always available, and it's not always indicated, only in patients with systemic envenoming or severe local envenoming. And there are questions about its effectiveness and safety. It's important to support failing systems, particularly in the case of neurotoxicity, it's going to be respiratory support. The use of ancillary drugs. Now, I mentioned earlier and showed you an example of the benefits of neostigmine following atropine in a patient with sea snake envenoming in Bangladesh. Then there's management of wound bite infections. In some cases, the infection, the secondary infection, if it spreads and becomes septicemia, can dominate the clinical picture and may be very misleading because people misinterpret these signs of overwhelming infection as being signs of envenoming, and they give antivenom rather than look for appropriate antibiotics. To ensure restoration of normal function, it's important to start rehabilitation of the bitten limb at an early stage, and to address the problems of not only physical but also psychiatric morbidity. It's clear that snakebite is a terrifying, devastating shock to the nervous system. So I mentioned antivenoms, the indications for antivenoms, any sign of neurotoxicity, even just early ptosis and external ophthalmoplegia. The effectiveness of antivenom, it can reverse postsynaptic neurotoxicity, sort of thing you'd see after a cobra bite, perhaps, within 30 to 180 minutes, because the postsynaptic neurotoxins can be prized off the acetylcholine receptors if a sufficiently potent antivenom is given. But you can't reverse presynaptic neurotoxicity because, as I've already emphasized, this isn't just nerve block, it's destruction of the nerve terminals, and recovery takes days until new synapses are formed. Antivenoms are not completely safe. Common early anaphylactic symptoms may develop, such as the urticaria in this man, and late serum sickness as well. And you mustn't forget supportive treatment, the essential role of supportive treatment. In this case, this is another Papua New Guinean patient with taipan envenoming, causing respiratory paralysis. He's being mechanically ventilated with an old type of a very economical ventilator in Port Moresby. Now, I mentioned the possible role of anticholinesterases. This shows one example of before the edrophonium in this case was given, the bilateral ptosis, patients even looking a bit cyanosed, and afterwards, 20 minutes later, obvious objective improvement. And to re-emphasize that the use of anticholinesterase is most effective against those venoms that have solely or predominantly postsynaptic neurotoxins, such as cobras and death adders in the Oceania region, and against some South American coral snakes. As an alternative to a test dose, so like the tensilon test, giving a short-acting anticholinesterase, such as edrophonium, intravenous edrophonium, is the so-called ice pack test, because here the ice cools down and effectively inhibits the endogenous anticholinesterase. Inhibits the endogenous cholinesterase in the region of the nerve endings of the affected eyelid, and has the same effect and is a good predictor of whether subsequent treatment with an anticholinesterase drug will be effective. Finally, I want to emphasize the value, the use, the interest of snake venom neurotoxins in neurology research. Just to remind you, I said earlier that snake venoms evolved to immobilize the snake's prey or to deter its enemies by targeting the receptors crucial for vital physiological functions. And it's this specific action of snake venom neurotoxins that have made them such useful tools or even therapeutic agents in human medicine. You remember the early ptosis in this unfortunate agama lizard seized by this tiger snake. I showed you that early on. Some snake venom neurotoxins have proved useful for identifying and manipulating important signaling molecules. Just two examples, really. In 1963, some Taiwanese neuroscientists found that alpha-bungarotoxin, that's a postsynaptic neurotoxin from the Chinese crate, would bind to muscle-type acetylcholine receptors, nicotinic acetylcholine receptors. And by labeling this toxin, they were able to localize nicotinic acetylcholine receptors in human tissues. This was very valuable in investigating normal and disturbed cholinergic synaptic transmission, particularly the pathophysiology of myasthenia gravis. And a second example, in Oxford, Professor Angela Vincent back in 2004 used labeled alpha-dendrotoxin, that's another venom I've mentioned during this talk, from the eastern green mamba to detect a specific subgroup of potassium channel receptors to diagnose autoimmune channelopathies, which affect peripheral, autonomic, and central nervous system. This has become a very large, actively growing area of neurology. For those of you who are interested to learn more about snakebite, there was a recent seminar in the Lancet, which I can't help recommending, which is still available. So thank you very much for your attention, and I hope I've interested you in the topic of snakebite.